Good evening, everyone. I'm Eli Silber. I'm a neurologist at King's College Hospital and at Lewisham and Greenwich. And I'm very pleased to be joined by Ruth Strauss, MS Specialist Nurse at Surrey, and Rachel Dorsey Campbell, who's the Senior Pharmacist at Imperial College, who've kindly given up time. These are our declarations. We've received funding from many companies. And the questions that we started thinking about when planning this is how do we best care for people with MS? How do we manage their expectations from their diagnosis and as their disease starts changing? What would we be saying to people, and how is it best to say it? Who should be involved in these conversations? Some patients refer to being told that they've got secondary progressive MS as being diagnosed all again. And there's this process of adjustment and readjustment. And how do we support people in this conversation? What's happened well that we've got treatments that are now licensed and available in secondary progressive MS, and are we now less reluctant to label people? Is the care of people with MS, and particularly progressive MS, still a postcode lottery? And a lot of people are smoldering in the community, are deteriorating. How do we access them, and how do we make sure that we're able to offer equitable services to the whole spectrum of people with MS? So this is a very typical case that many of us will see on an almost weekly basis. A 48-year-old man, relapsing remitting MS. His first symptoms were in about 2010. He had a number of relapses and was eventually diagnosed in 2014, which is a pity, but certainly not uncommon. He started one of the platform drugs in 2016, and he stopped that because he was fatigued after about 2 years. He'd had enough of treatment. He has a relapse. He starts on an oral therapy 18 months ago. He was a runner, but he's now tired after walking 20 minutes. He's managing about 500 meters. So he gets his COVID immunization. He describes fatigue with increasing weakness and sensory symptoms in his legs. He's had a gradual recovery, but is less active. And we managed to do a scan 2 years after his last one, and it now shows 2 new cerebral lesions. So it would be interesting to hear what type of MS does he have? How confident are we at distinguishing a relapse from a pseudo-relapse triggered by an immunization, triggered by an infection? Would we treat him with steroids if you think it's a pseudo-relapse? Does this count as treatment failure? What would have happened if his scan didn't show new activity and it was stable? He's on one of the platform oral therapies. Would we change therapy at this stage? Would we choose a drug licensed in relapsing or secondary progressive MS? What should our conversation with this man include? And how do we manage his care moving forward? Anyone who's got comments, any questions, anyone who wants to type anything?
No questions at this stage, Eli. I mean, the question about whether this is a treatment failure is an interesting one, because that comes up in our MDT all the time, about whether, if you have, putting aside whether this was a genuine relapse or not, whether you have one relapse or whether that constitutes treatment failure, or whether you should continue on the same treatment, is a conversation we have quite often.
What do you think?
I don't think it constitutes, if putting the MRI findings to one side, having disease activity on a treatment, I wouldn't say constituted treatment failure. I always, in my discussions with patients, say, well, we don't know how much activity you may have had without the treatment. So there may be a reduction in your treatment activity. But I have colleagues that disagree with me on that and are very quick to escalate people if they've had that kind of activity on a drug.
Ruth?
I guess from my point of view, I'd be wanting to talk to him about, ideally as a nurse, build up the relationship. We hopefully will have met this person before and had sort of, conversations from diagnosis around expectations, around their treatments and kind of where potentially the treatments will go. I guess you've also mentioned he's a runner. So for me, the conversation wouldn't just be around the DMTs. It would be around, he's struggling with his running. Maybe that's affecting his self worth and you know, his mood, etc. So I'd be really wanting to, I think that if we want patients to trust us around discussions with DMTs, then we need to engage with everything else that they've come to the appointment to talk about. And it may be that we're looking for, say, whether it's cycling or is there some other activities, swimming, is there something else that he can do that is going to better suit him? He's obviously someone that wants to do activity, he wants to engage in regular exercise, which is with the health, you know, disease modifying lifestyles, we're really becoming a lot more proactive from when I first started working in MS, you know, really pushing patients to do that. So I'd go at it from that and hopefully engage and get a bit more trust, and then it is about, you know, a conversation with regards to what you do with the treatment. And then from my point of view, that would be very much joint with the neurologist in the MDT.
So, I mean, we have exactly the same arguments in our MDTs, and I tend to be more aggressive. And my feeling is one relapse is one relapse too many, whereas some of my colleagues would be more sanguine about it and say, well, this is a pseudo relapse. He'd had a vaccination and perhaps leave it. But I do worry about this window of opportunity. You know, I'll show you the next slide. And what's really interesting is this is from 2000, and this is the days before disease modifying therapies. And anyone who hasn't seen this this paper by Christine Compreveau and colleagues looked at a large French registry. And they looked at disability with MS. And if you look at the larger set of slides on my left, the top one is people with relapsing disease, and the bottom one, the grayer one, is people with progressive onset. And they looked at how long it took to get to an EDSS of 4. And within 10 years, virtually everyone with progressive disease was hitting an EDSS of 4, whereas about half of people with relapsing remitting disease were hitting that. But once you hit an EDSS of 4, they then looked at how long does it go, what proportion of people go from an EDSS of 4 to an EDSS of 6. And the bottom one is going from an EDSS of 6 to an EDSS of 7. And whether you've got a relapsing onset disease or a progressive onset of disease, it seems to be following exactly the same pattern. And I think that by the time people are struggling to walk 500 meters, they've probably got early progressive disease, and we should be managing them as that. To be truthful, I don't tell my patients with an EDS of 4 that they've got early progressive disease, but it does make me want to manage them as actively as possible in order to try and alter those curves.
So Eli, in that case study where you've got somebody who's at that point, would you be looking to put them at a more active treatment for relapsing disease, or would you, now that we have alternatives, be thinking about putting them on a secondary progressive drug?
So I would still label them as relapsing disease at this stage, and I would still label them because I think that they've got new activity. I think that they may have had a relapse, even if it was a pseudo relapse, and I think that labeling them with relapsing disease gives us a greater spectrum of opportunities than labeling them with secondary progressive disease. But in the back of my mind, I might start calling this transitional disease. I might start talking about a gradual buildup of disability in addition to their relapses. And so I think that there's a slight disjoint between what I'm thinking and what I'm saying, but I would still tend to manage them for active relapsing disease.
Can I?
Yeah, please.
I was just thinking, while we're having very sort of limited time conversations with patients when they see us in clinic. So one of the things that I do is really signpost to other places where patients, we obviously want to not control, but we do want to signpost patients towards where we feel they're going to get beneficial information and accurate information. So I particularly signpost to Shift MS, which is a patient led online MS community. And I find that they often learn a lot of these. We worry about having conversations like this in clinic, but actually they've already spoken or seen or, heard. And to make that a more of a positive experience, Shift MS have been really good. And obviously the online MS charities. But
Absolutely.
There is, I do think that has, especially during lockdown, there's been quite a lot of online, support that patients will have accessed. So where we've not actually had the engagement as much as we would have liked.
And it's much better for people to get good, positive, reliable, well thought through information than not. Absolutely, and being able to engage with people. I think that there are very few people that come to us completely naive at this stage.
Yeah.
If we go on to the next slide, and this is a question of how do we start diagnosing treatment failure, and these are the Rio or modified Rio scores. And essentially, if you don't look for failure, you're not going to find it. And if you don't see your patients every year and monitor them and ask about relapses, and if you don't scan them, and if you don't look at their disability, we're not going to pick it up. And so please, when you're seeing people, keep thinking, is what we're giving them appropriate? And if it's not appropriate, and if it's not the best possible treatment, let's think about changing options for them. Are there more lesions on the scans? Have they had a relapse or not? Has there been an increase in their EDSS? And I think, again, the difference with these transitional patients is that those changes can sometimes be incremental. I used to walk my kids to school. Well, I now stop on the bench and I need to wait a little bit. In the Southeast, we've got the Blue Water Shopping Centre. It's like, how many, sides of Blue Water are you able to do? Are you still able to go shopping? And it's probably a little bit like middle age with all of us, that these tiny creeping changes that happen. Hi, Heather. Can someone read what Heather's saying?
Yeah. So the combination of both a relapse with incomplete recovery after some time, so perhaps more like a true relapse, and the new MRI activity supports ongoing active inflammatory disease. Unless I had a very clear story of relapse independent decline, I wouldn't call it SPMS.
Yeah, absolutely. Absolutely. I think that we would all agree. Does anyone disagree? Has anyone else got other thoughts around that? I can't see who's in the audience to pick on people.
We haven't, nobody's coming forward with an opinion just yet, but please feel free to put it in the Q&A section if you have a comment.
Can I just ask, with your two centres, do you use Xtavia for secondary progressive?
We
Not
don't.
really, no. No. I would much rather keep people on a more potent therapy than de-escalate.
So yeah, historically we've transferred a couple of patients onto Xtavia, but they haven't been able to manage the injections. Their dexterity is not good. It's just, it's not been successful.
I think that some of the licenses are also a relic of previous studies and a relic of 20 years of build-up that's happened, and so they're kind of fossils in the layers of strata, and it's much better to think of drugs in a class way than to kind of look for those fossils in the strata, if I could use that bad analogy. So until now, have we been too nervous to label progression? And are we scared to call a spade a spade? And is it that we're trying to protect our patients from bad news? Is it that we're scared and we're trying to protect ourselves from sharing bad news with them? Are we concerned about depriving or limiting therapy choices? And we can have a discussion about blue tech. And are we having difficulty supporting patients through this adjustment in a brief consultation? And so it becomes almost too difficult, and so we avoid those. Any thoughts or comments?
Sorry, Rachel.
Go on, Ruth, you go first.
I was just going to say that actually this is where the MDT approach is absolutely crucial. You need to identify who knows the patient. Often you've got, one member of staff who have been there quite a long time. And so it isn't a conversation that happens in time. It's a gradual conversation over time. And if you look back on the notes, there will often have been things that have been mentioned, and it can come from any member of the MDT. So I think that having MDT meetings is the most important thing, so that there's feedback and that we communicate, what conversations we've had, because I don't think that it is as finite as, are we nervous to label progression? I think it is something that just, is a continuing conversation. Absolutely, we do need to make the choice as to when we move them to the secondary progressive MS. Although we had the conversation earlier about, it's back to a label. Is that helpful? So over to you, Ray.
I would say, I was going to say that I think I've certainly come across an element of people worrying about having that conversation with patients, and maybe, you know, a different member of the MDT can approach it in a slightly different way, and as a pharmacist, and I maybe have a slightly different approach to things. But in my experience, when you do mention to patients that they may not remain eligible for a treatment and that you would have to consider, I mean, you always need to give them a long run into that idea. You know, you plant the seed early on and say, you know, just, you know, if this drug doesn't continue to work for you, we may have to stop giving it to you. Or if you reach a stage of your disease where you're more progressive, then, you know, we may have to stop giving it to you. And you mentioned blue tech, Eli. I mean, there is a tick box on the form when you start treatment that says, have you discussed stopping criteria with the patient? And we all merrily tick that form, and very few people are actually having that conversation with patients. But in my experience, it's quite well received, actually. People like to think, you know, that they're not outraged, you know, that you're mentioning that at that stage. They like to understand what the end point might be, in my experience.
And certainly in early, you know, many years ago when we started people, we had difficult things of people saying, I spent X number of years trying to get onto a treatment, and now that I'm on it, you're now trying to take it away. Now that we've got a range of drugs, and a range of drugs that are licensed at the different disease stages, I think people see themselves as moving from drug to drug, rather than I'm on this and you're not going to be able to remove that from me.
I think in the past, people have been really concerned about being discharged from services.
Yeah.
So as we know, historically, a lot of patients were discharged when there were no treatments, or just discharged full stop. And then there's a huge amount of patients that completely lost follow-up.
Yeah.
And I mean, even as a community service, we know there's a lot of people that we don't know about. And we do sometimes, you know, patients will see their neurologist, have some of these conversations, and then there's a bit of a fallout, and they'll have time to think about it. And then we pick up after that. So that's where communication is really important. And then we'll have a conversation in a month, you know, a few weeks later, and they will have already processed a lot of that conversation. So I think, and everybody is going to react differently. So the conversation has to be aimed at an individual.
Good. So I'm going to move us on from maybe early or transitional disease to more advanced disease with the next slide. So briefly, how good are we at predicting progression? We know that gender and age of onset and concomitant diseases and smoking will determine to some extent, as well as the number and severity of relapses and the load and responses to therapy and disease duration. But to some extent, these are models that will help to predict in general, but not necessarily for individual patients. So this is a 55-year-old woman. She's hypertensive and a smoker. She was briefly on platform therapies, again, about 10 years ago, but had breakthrough disease and was started on a monoclonal. She's had no relapses, but over time she's deteriorated, and she's now coming into clinic with a wheelchair, walking with a frame indoors. But you know, the infusion nurse who's been seeing her can clearly see that this is becoming more difficult. She's had a couple of falls. There's some cognitive changes. And she said to us, if you stop my therapy, I have no hope. So when do we think about stopping therapy, and how do we decide, and how much do we obey the rules, and are we worried about breakthrough disease? Questions, comments? Heather in the audience?
Can I make a comment, Eli?
Yes, of course, please.
I think before I would have any conversation about stopping therapy, I would again go back in looking at symptom management. She is, you know, she doesn't lead a very healthy lifestyle. So I would talk about stopping smoking. The patient needs to know that they trust us, that we, you know, we are ultimately wanting to improve their MS, so that rather than going straight in with the drugs, actually the disease modifying lifestyle is as important.
Yeah.
Her age is quite a factor. You know, some of her symptoms could be related to menopause, so just, you know, discussions with the GP and sort of signposting to help deal with things like that. We can't assume that we know where some of these change in symptoms is coming from.
Absolutely. And in terms of lifestyle, we know that smoking, we know that hypertension, we know that obesity, you know, increases inflammation, but also increases the risk of small vessel disease, and is a poor prognostic factor, and absolutely agree with doing that. We've certainly stopped patients on potent treatments, and then a few months later, we've seen them having horrible relapses.
Yeah.
And so I'm very worried about saying this disease has burnt out and stopping treatment. And I tend to keep people on.
Yeah, and that's what Heather said as well. She would worry about potential rebound, especially if it's a monoclonal such as Tysabri, as she's had that experience as well.
Absolutely.
And I know, yeah, my clinicians, I often play bad cop in the MDT in terms of sort of reminding people of the rules around, you know, stopping criteria, especially when we've got patients coming to Tysabri in a wheelchair, and you know the EDSS cutoff is 7. That is what we're supposed to enforce. Obviously, you know, just because someone's coming to their appointment in a wheelchair doesn't mean they're confined to a wheelchair. But you know, having some discussion about their EDSS assessment, I'm often raising that in MDT and getting exactly that pushback in the terms of, you know, what happens if we stop this drug and the patient has a massive rebound relapse, and you know that's a very real risk of therapy.
And that's assuming. Sorry.
Carry on.
So that's assuming that we have the EDSS. So obviously we've been seeing a lot of patients virtually, and I'm community based, feeding into about 15 different centres. Lots of our patient letters don't have any EDSS.
Yeah.
So is that because people don't really want to put it down? I don't know. It's obviously, I know some centres have been doing an online one.
See, I feel quite strongly about this. I think that we should be honest about, because unless we're recording for NHS England the size of this problem, we're brushing it under the carpet. And we all know that we have quite big populations of people on treatment for relapsing remitting disease who probably have reached EDSS 7. But unless we document that and highlight that, I don't see that we're helping the situation in terms of finding a solution.
I think that we're worried about exposing our patients. I mean, we've certainly de-escalated our patients to many patients to fingolimod very successfully. There have been a few unsuccessful de-escalations, but I would be very, very loath to stop treatment. I think that you know, the early EDSS stages, it's sometimes very difficult, but the hard EDSS stages of 4 or 6 or 6.5 or 7, I think that we're able to get reasonably accurate outcomes on a telephone interview, and that we should be at least doing estimated EDSSs.
So my question to you, Eli, is do you think patients are very aware of criteria for DMTs and what might constitute them coming off treatment? How do you think this might affect the phone interview of, I mean, this is, I guess, if we don't know our patients as well at the moment during COVID.
I might caveat it and say that based on my telephone estimation, it is, and it may allow a degree of wiggle room. Sometimes we can be a little bit more liberal with that, but I think that we need to be honest amongst ourselves. But at the same time, there's a balance between advocating for our patients and again being cautious and honest with it.
Yeah, and I guess ultimately to reduce variance and improve standards of care, especially around progressive MS, that's not going to happen if we don't record the EDSS.
Absolutely.
As you say, Ray.
Absolutely. Do you want to lead on this, Ruth?
We just thought we could reflect on the case studies. I know a lot of this is happening within all of our services, and this is very much something you know. So I guess we just wanted to not necessarily talk through all the points, but just reflect, having looked at the 2 particular case studies. We are working with a much wider MS MDT, which I find really exciting. There are so many more people involved. We're all meeting virtually in my community service. We meet weekly with our local MSologist, and then on Fridays there's a regional meeting with St George's, and then we have educational meetings. So for me, I am far more involved in what is happening in our region now because we have access through virtual working from COVID, and then it's all the things that we know. Obviously, it's very much about developing a relationship with patients, as we said, and involving family members. And I really encourage patients to bring family members to the appointment if they want to bring their children. There's certain times I think that actually, they go home, and I'm sure that there's a lot of, obviously there is issues they're dealing with at home, but actually including them in the conversation and bringing them in, even at the moment, maybe we're not allowed and there's restrictions, but ultimately I think this needs to be, we're at MDT, and ultimately they are their own family unit at home.
Yeah.
And then learning from each other as we're doing here.
Yeah, I was just saying, the important point on that one for me is I think taking the lead from the patients.
Yeah.
Because quite often patients will themselves say, well, I don't really think I'm having relapses. I think I am progressing. And I think it's important to acknowledge that they've that they've noticed that as well. And it's like you say, it's a long-term conversation, isn't it? There has been a question or a comment come in. I think it's a comment. As Ruth has raised, we need to promote the role of exercise and activity in the management of MS. Growing evidence regarding brain atrophy and decline, and the lockdown has emphasised this more than ever. Deconditioning can be reversible if caught early before secondary complications such as spasticity and loss of range occurs.
I think that this was one of our bugbears. I think that the lockdown maybe saved some lives in terms of exposure to disease, but at the same time, it was a huge step back from people who were managing and holding out and walking to the shops and keeping active. And suddenly, 6 months later, they've had this step change, and we've really, need to encourage people to keep moving.
I was just going to say it's been a huge issue. I'd say about 90% of the patients that I'm seeing have had some deconditioning, and it's educating myself and educating my colleagues that obviously deconditioning can be improved, and that's the message, that it's really hard to get through to everybody, that we need to be active, and there's huge waiting lists to see therapists. So
I was going to say that's a problem, isn't it? Access to therapy and physio. And especially through lockdown, where a lot of people's regular physio input was just stopped. And I've spoken to patients who are still only getting phone calls from their physiotherapist asking, how they're doing, rather than any active therapy. So it's a real issue.
This is where we need to signpost. There's Staying Active in MS on the MS Trust. There's loads of webinars from the MS Society looking at specifically exercises. There's YouTube videos with Pilates. I've been really quite pushy about saying to patients, little and often, just whatever you can fit in. I've had a patient recently who I saw actually today, she thought she was having a relapse. She's got huge edematous legs. She's put on a lot of weight, 2 stone in about a year. And when it came down to it, she's sitting, working full time and studying. And basically, there's no movement. So we've discussed what she needs to do to kind of, so it's actually more around lifestyle and
But there's also an equity issue that people who've lived in greener areas with access to outdoor spaces, which has been safer, and access to parks, have found it very much easier than people in more deprived areas. And I think that the highlight, the lockdown has really highlighted these differences in terms of access, and that we really need to be advocating for those hidden patients as well.
And the effects on mood as well. So, again, it's signposting to services, because I find patients obviously they struggle to engage with any therapy or any kind of exercise regime or anything related unless there's effect on their mood, if they have any anxiety or depression. So, we need to help support patients with that and signpost.
Absolutely. Should we move on to the next slide?
Yeah.
Ruth?
So I got this quote from the MS Trust website, actually, and I just thought it was a bit of a kind of a wake-up message, that actually it is, as Eli said on the previous slide, potentially some patients find it's just a label. So we do get a bit, hooked up with SPMS and the different types of disease, but ultimately it is one disease, and we are talking to patients about how they move through it, and letting them know the support that's available. So I think for me, this was just a reminder that everyone will react quite differently, so we don't need to assume the conversation. I don't know if you want to add, Rachel.
No, you're right. I think people prefer to talk about how to manage their disease and are less concerned with whether they are one type of MS or another. Quite often, they just want to, like you say, get some help to live well as they are.
There's a lot of grey areas.
Yeah.
This slide was that there was an expert panel report, a consensus report that came out. Actually, Rachel was on that last year during COVID, and it very much talks about the forgotten many of people with secondary progressive and ultimately just progressive MS, and how they sort of describe themselves and the impact of their disease. And being honest, even as a community service, we are really struggling to see patients, to engage with patients, to do the home visits, to do all the parts of the role that I loved when I started it, because of constraints of lack of we don't have the establishment, we don't have the capacity within the service. So this report very much highlights that.
Yeah, and I think what the sort of the point of view that I brought to the report was around, I mean, you work in a community service, Ruth, where big centres, who sort of acute setting centres, are very much focused on disease modifying therapies. I'm sure Eli will agree. We don't have the capacity to see patients and give patients time. If they're not on a drug, they get a very sort of second-rate service, I think, if they're even being seen in these big centres.
I'm proud of the fact that we never discharged our progressive patients, and we've worked very hard. We work with nurses in Southeast London, based in the community, and we've developed relations with our community rehabilitation teams, with regular MDTs, in order to make sure that these silent patients or these lost patients weren't identified, because I was finding that, them coming in once a year in a stretcher to be seen in clinic is completely unhelpful. And I think that this is maybe where lockdown has been an advantage, and that telemedicine and different ways of working have maybe been able to link us more to these lost patients, rather than expecting them to come into this palace and wait a long time and be seen. We can actually bring our services out to them and reach out to them a lot more.
And actually, there's the MS Trust are looking at mapping MS services again over the UK this year. So I think that will really help, because I think where there are some issues, and there's an issue in my area, in one of the sort of boroughs nearby, that there's a hospital-based MS service, but for the patients around them, if they're not known to the neurologists at that hospital, there's no care, there's no community-based service. So if we need to have regional centres like you're describing, Eli, where teams work together, so that there are no areas that are completely missed, which is unfortunately happening now.
And we've spoken in different meetings about the barriers for much more advanced people with rehabilitation and palliative care. And actually, our patients really don't care who looks after them. It's a question of where the care comes from. The label really doesn't make a difference. And I think that working in these silos or bunkers might protect services that are overwhelmed, but it really doesn't do a service for our patients.
I guess I put this one in because ultimately, the people that we're talking about, the people with MS, whatever type of MS they have and whatever part of the disease process that we are seeing them, this is their quality of life. So we see them for a very small snapshot. And, we need to be really very much aware, as I'm sure we all are, about their own value. And their value might not be the same as ours. So, what their reactions to what we're discussing could be completely different. So I felt this quote from the World Health Organization was just quite helpful.
Their sense of agency and their sense of what's important to them, and their ability to control what happens to them, I think.
Yeah, absolutely. And that leads exactly into this slide, which is basically, this was published by the MS International Federation, looking at 7 principles to improve quality of life. And the top of the top of the 7 principles is very much about patients wanting to have a central role in their decision making. And I know we use the word empowerment quite a bit. Ultimately, patients want that to be a discussion so that they are informed, but don't necessarily need to be given the responsibility to make that decision. But I think it's just really important for me to keep reminding myself about values and the quality of life for the person that is presenting in our clinics, which feeds nicely into the next slide. And this is what's going on when we see a patient in clinic. They're dealing with all of these symptoms, with all of these issues at home, especially if they are transitioning to a progressive type of MS. And, they may come into our clinic appointment with a completely different, what they would like to get out of it. And I do recommend that when they see neurologists, I say, please write down your questions. Please go in with exactly what's happened so that you can get through that bit really quickly. Just, put down what's happened since you last saw your neurologist, and then put down questions that you'd like to ask so that you get something out of that. And then obviously then there's what we would like to talk about. But I just think that it's a good reminder that this is all what's going on. I don't know if you want to comment.
I had medical students in my clinic, and I said to them that often the most useful sentence is, okay, we understand where you're at, but what do you want from me? And what would they like from the consultation today?
I agree. I think that's really important because and it's often missed, again, with a drug focused conversation. In the clinics I run, it's all about the drug. So it's really important to allow some space to say, you know, is there anything else you want to talk about today, or is there anything else you need addressing? Sure.
And I think that's a really good point. I mean, we do try and have DMT clinics, even in the community service. We prescribe the first line DMTs. We have DMT clinics and then clinics where with non-DMT, but it's not as easy as that. Patients will, you know, obviously turn up to an appointment and they have things that are going on in their life. And especially at the moment, there's a lot, you know, if patients are seeing us, they haven't seen us for a couple of years. So there is a lot that we need to cover in that small time.
You know, I think that care is care, and whether someone's on a drug or isn't on a drug, or whichever drug they're on, we're looking at that whole person. Yeah. And, you know, there's no value in just looking at the disease modifying therapy and saying, let someone else sort out their bladder or spasticity or depression or pain. It's part of that person.
I agree. I think if we don't do it like that, we're not going to build up trust with the person, so that they're not going to engage with any treatment. Do you want to talk through this, Ray, or do you want me to?
I can do, yes. Yeah. So this was the panel that was pulled together. I can't believe it's only 2020. It feels longer ago than that now. And the urgent concerns were basically sort of the conclusions of the report, were the things that the recommendations that were being made, was to understand the scale of the secondary progressive MS population. Until recently, we've had no treatment for these people. And as we've discussed already, some of them were often discharged from services as it was felt there was nothing that could be offered for them. So we need to identify the population, develop guidance for that group, that specific group of patients, to aid prompter diagnosis and help get them the support that they need, establish a pathway, a nationally agreed pathway to try and remove local variation in the care that patients get, and so that they're engaging with a wide range of professionals, and use data better to understand the needs of this group of patients. Those were the main concerns that came out of the report.
So this was quite an interesting snapshot. I thought I would pick two services. One is hospital-based, one is community. I looked at the population for those areas that the hospital cover against the population of people with MS. And so in Southampton, the patients on their caseload is around 2,000. The population in that area, the areas they covered of people with MS, is over 4,000. So there's around over 50% of patients that are lost to follow up. Now, I'm sure that there are some community services in those areas that may be being picked up. But ultimately, if we're looking at treatments that patients might be eligible for, they need to be known to the regional centres. And it's those conversations that are quite tricky without putting too much pressure. I know Eli said you didn't discharge, but a lot of services have discharged to community services. So then it's like, you know, do we refer back in, or how do we facilitate those patients? And ultimately, there's potentially 50% of patients who are completely lost to follow up and being managed via their GP, or just, I saw a patient today who was diagnosed in the 90s. She's 50, she's exactly my age, and she hasn't seen anybody since diagnosis, and she's just been told she has secondary progressive at the age of 50, having had no DMTs. So, you know, obviously we're looking at eligibility.
I find this fascinating, Ruth, because as a pharmacist coming from a drug therapy driven background, I was always surprised by those slides that show that in the UK we are quite far behind other countries in the percentage of people with MS that we have on treatment. And I'm like, well, everybody we see gets given a drug, so that can't be true. And then you look at this and you realize that how many people are actually just not accessing the service.
Absolutely. And I'm a community service, and we're still missing over nearly 25% of our patients in the local area. And I've done quite a lot of canvassing with GP practices. So looking at how do we access these patients, I've approached GP practices, GP practice managers rather than GPs, and been out to speak at locality meetings, just to sort of promote what we do in our service. But ultimately, there's, even within a community service, there's a lot of patients lost to follow up.
So in London, I think that there's a degree of overlap, and some people may be seen in other centres. But as soon as you move out of London, there'll be a degree of cross centres, people being seen in different centres. But I think that it's much more likely that they're lost. The one thing that we're piloting with our epilepsy specialist nurses is patient passports. that says you've been part of the service, you're going to be under the community team, but if there's a problem, this is the way that you can re-access our services, so that we never discharge, but we can potentially bring people back in as necessary, and they can trigger their own referrals back into a service.
Yeah, absolutely. The difficulty with triggering referrals, sometimes we talk about the annual review, which I know we're not covering here, but ultimately that's quite a good way of making sure that patients aren't lost to follow up. So if we just use the NICE guidance and made sure patients, so when in a couple of services I've been sort of moved across to, a lot of patients were just, they would phone if needed, and so we contacted them and said, we'd like to see you once a year, even if it's on the phone, just any way, so that then it means that you're at least having some kind of catch up. But
we would expect a hypertensive or a diabetic patient it would be completely irresponsible if they didn't have at least an annual review.
Yeah. And just a point I'd like to make, just as a word of caution, it's great to go actively looking for this population, because they're the forgotten and the lost, but we don't have the capacity and the resources to offer all of these people. If Mavis got 2,000 people turned up at her service tomorrow, that's doubling their caseload. They're sure aren't going to be able to cope with that very well. And the other thing is, I think we really need to manage the expectations of the patients who are secondary progressive, truly secondary progressive, in terms of treatment that we can offer, because we know that the only treatment we have available, and the second half of this evening will address that, is for a specific group of patients with activity, and not for people who've
absolutely. But if we
been
can
at home for a very long time.
But if we can avoid urinary tract infections, and if we can identify osteoporosis and prevent osteoporotic fractures in these patients, it won't only improve their quality of life, it will also have a public health benefit.
Definitely.
Yeah.
Ruth?
So, yeah, I guess it's just really summarising what we've been discussing. A lot of the questions we haven't particularly answered. I guess it's just starting that conversation. There is lots of evidence that aggressive sort of, healthy lifestyle and, information and education to patients around MS-related comorbidities. And there's lots of evidence out there that we can signpost patients to. And I think it's really being quite honest about that. So I think that has really changed from my point of view in how we manage people with MS over the last few years. Working in partnership with patients, which is what Ray was very much saying, ultimately it is about building trust and involving them in the pathways. We need to be improving on the NICE guidance. There's lots of areas that are not covered at all, and that's what we need to. If it's included in the NICE guidance, then based with the data that we have, we should hopefully be able to increase capacity in MS services, so that we will be able to cope with the patients when they come looking for MS care, and yeah, ultimately it is looking for the forgotten many. So
absolutely. I guess the other thing is another advertisement for the multidisciplinary team. And there's a book that's recently come out by Daniel Kahneman called Noise, and looking at variability and the way that judges or doctors manage patients, and that working together and sharing thoughts in an equitable way means that we're much better able to come up with better treatments and improved care for our patients.
Yeah.
Well, I've really enjoyed the session. Rachel, Ruth, thank you very, very much. Thank you to everyone who contributed and to the MS Academy who set this up. We would very much value your feedback. I think it would be nicer to see members of the audience and to have a way of contributing. But thank you very much indeed to all. Ruth,
Thank
Rachel?
you. Yeah.
Yeah, thank you very much. Thanks, Ela.